Hello and welcome to the Brander Macco podcast. I have with me today Cheryl Cammock, and she is a pediatric cardiologist, and she is the founder of My Pediaheart Care Partner.
Yes.
And pediatric cardiologists, most people think cardiologists, they think the elderly and having heart attacks. And I've really wanted to have you on the podcast because people have real concerns lately because of, kids dropping dead, heart issues. So I've heard people talking about this, worried about their kids. So I've been excited to have you on. Maybe to start, thank you for being on the podcast.
Well, thanks for having me. This is great.
And maybe I could have you go into where you are and how you got into healthcare and how did you get into cardiology?
Okay. So my practice is a small private practice. We're located in New Jersey and Pennsylvania, mostly North Jersey and eastern part of Pennsylvania around Philadelphia area. Started that practice a few years ago. And I got into pediatric cardiology because one, I always loved working with children, but cardiology because in children, unlike adults, cardiology is very different. We're dealing with congenital heart defects, where the parts just don't fit together right. You're not born with all the structures normal. And then we have to figure out how to manage that. So that's what drew me to pediatric cardiology. I'm especially trained in taking care of children with really profound heart defects, and also children with myopathies, which is weak heart muscles that require assisted devices, heart transplantation. That's my background. And so here today, I'm working with all types in my practice.
So maybe we could get into some of the details, some of the challenges you mentioned, heart transplants. Do these children are some of them able to have full lives? Or is it always going to be a struggle for some?
Actually, yes, some of them can have full lives. The thing that has gotten them to that point where they need a heart transplant, those are variable. Sometimes it's a heart defect that they're born with. Sometimes it's like a virus that has attacked the heart and that made their heart weaker. And then they're ending up with end-stage heart failure requiring the heart transplantation. Once you have a heart transplantation, it is a disease in and of itself because you're needing constant monitoring. But the lifelong expectancy is pretty good, especially in those that are transplanted when they're very young.
So I have now I thought of a question because I read, I don't know how many, but not too long ago about experimental full heart transplants, and I know they've been doing valve replacements, like plastic titanium pieces, like artificial hearts. And has any of that made its way into children? I'm guessing it doesn't grow with the kids, so maybe it's not.
Doesn't grow with the kid. No, they haven't made their way as a replacement therapy for a transplanted heart.
Okay.
So no, not yet.
Yeah, and with kids growing, I'm guessing that it might never really suit children. It might just be for the elderly.
Yeah, yeah.
Now, maybe I'll jump straight into what was in my mind when I first heard and wanted you on the podcast, and it's the myocarditis, it's the children dropping dead on the field, has people scared, young athletes dropping dead on the field, seems to be happening more and more, and it has some parents terrified.
Yeah.
And what do you say to these students? Obviously, there's a link between either COVID and or COVID vaccines as increased risk, is what I hear. But yeah, so sports, myocarditis, and what are your thoughts?
In general, sports very, very, very low risk.
Okay.
In general.
Okay.
In fact, we encourage it, and I want anyone that is listening to know that we absolutely encourage sports participation. The risk of sudden death is very low. It
That's
ranges, you can see a range of and I'm hesitating on this because the risk is different depending on who you are and what you're doing. But the general knowledge is about 1 in 50,000 individuals who are in highly competitive sports have died suddenly during their events. And that risk is dependent on what you're doing and who you are. There are some populations that are more at risk. Those that are qualitatively higher risk are those that are African American male basketball players. They have a higher general risk. Well, the incidence, I would say, not risk, but the incidence of sudden cardiac death is certainly higher in those groups than in most others. And the reasoning for that is not 100% clear. It's some references will say, it's because there's a higher risk of Marfan syndrome in athletes who do basketball because of the body habitus type that will be, geared toward basketball.
Yeah. For the audience, sorry to interrupt. For the audience, Marfan syndrome is it's a genetic disorder. It's often connected to collagen. They have very stretchy skin. They tend to be very, very tall, very lanky individuals.
Exactly, and the stretch arm length is wonderful for shooting hoops.
Yeah.
So that was a thought at one point. There still may be a little bit of that as a risk because we do see patients with Marfan syndrome have a higher risk of cardiac death because of the risk of aortic dissection. And for the audience, that is when a part of the aorta is the blood vessel that sends blood to the body. It is the main blood vessel. And if parts of that pull away, become unstable, there's a risk of rupture or aneurysms formation. And that eventually, it's a sudden event, and it leads to decreased blood flow to the body, the organs, brain, and everywhere. So that risk is real, and that may be a contributing factor.
So that would also impact, or other people with other collagen disorders may also be impacted as well. I'm thinking of Ehlers-Danlos. I have a mild form of Ehlers-Danlos, which is also stretchy skin. I like in the diagnostic criteria, it's sometimes written as velvety skin. Oh, I do have velvety skin. How nice of you. Yeah, thank you, academic article complimenting my skin. But yeah, extra stretchy, good flexibility, and the more severe forms, they do have vascular disorders associated with Ehlers-Danlos. So I guess people with Ehlers-Danlos may also, following those theories, have, just like for Marfan syndrome, they tend to have similar associated problems, maybe at an increased risk. Can screening actually, so if someone's in a high-risk group, can you catch something before someone dies? Can screening help?
You can. It depends on the type of screening that is done.
Okay.
So your first level of screening is always history and physical exam. The history is critical. The history should include the family history, first degree relatives, second degree relatives, as far back as you can go, but especially the primary mom, dad, brother, sister, grandparents. And we're looking for things like sudden death in those family members before age 55. Early premature coronary artery disease is important too. Family history of drowning for unknown reasons, car accidents, unknown reasons, because these can be a red flag that there was a undiagnosed rhythm disturbance that's suddenly led them to pass out while driving or swimming. There's a long list of questions that pediatricians are used to asking prior to sports participation. So after that first level of questioning, what the AHA and the AAP both agree what those are, you then go to physical exam, and you're looking for things like what you mentioned, things that are phenotype or the physical appearance of things that put you at risk, things like Marfan syndrome. But that's typically between the history and physical, you can narrow it down and start to think about, well, what are the additional risks? Other things in the history are related to the patient themselves. Like, is there a history of chest pain, rapid irregular heartbeats, dizziness, or passing out with exercise or without? And those things really help you to focus down. Do I need to do more testing or refer to a specialist? If any of those things are positive, then they're referred to a specialist like me, or others who are focused on athletes and their hearts. And then testing is done. A screening EKG is very good at looking for baseline rhythm disturbances. There are a handful of rhythm disturbances that put a child and adult at risk that are undetectable when you look at a person. You won't know from the physical exam. Sometimes you get clues from the history, but the EKG is very nice because it can rule out some of those more, there's some of them are rare, but some of them are not as rare, like prolonged QT syndrome, a little rare, but that's one of those risks that we see on an EKG. It's pretty clearly defined.
So maybe I will, sorry to interrupt, but EKG for the audience, this is that pattern, and there's different patterns. Each peak has a letter associated with it. So what she says, an extended QT is what I think you said, or prolonged QT. You're talking about the time distance between two of the parts of a heartbeat, right?
Yes, exactly.
Okay.
It is the distance and time between when the heart excites and relax. That is the time frame.
Is the EKG, is that a stress EKG? Is that them at rest, or do you have them on a treadmill running?
No, we typically do them at rest.
Okay.
You come into the office just at rest, and it will show a long interval there. Most forms of prolonged QT will show that way. Some will not. Some you can have prolonged QT syndrome and have a fairly normal interval, but that's when family history helps to determine, could this still be a problem for you? But that's one of the things.
Not necessarily for QT syndrome, but in general, is a stress EKG useful?
Stress EKG can be useful, but not typically done.
Okay.
A stress EKG is used for if you find something abnormal on the baseline EKG, a stress might be useful. Or if there's some history of symptoms that occur only with exercise, stress EKG will be used in that situation. Or if you're on some medicines where you want to see the effect of it while exercising, there are a few other scenarios where stress EKG would be used, but mostly the resting EKG is standard.
So I might jump to another topic, I think risk factor, or am I going to ask this if it's a risk factor, is obesity. Obesity, people think obesity, and the US has a huge obesity problem, and childhood obesity is a problem. And is that increasing risk as well? Are there heart problems in the young associated with obesity?
There are, but if I'm thinking you answered your question correctly, there's risk of acute sudden cardiac events, and there's long-term risk.
Of course. Oh, of course.
So if we're talking about acute sudden cardiac death from obesity alone, I would say the chance of that would be low, extremely low. But long-term, yes, there are risks there. And that is similar to what occurs in adults. The risk would be atherosclerosis, coronary artery disease. And sometimes we can see that in your early 20s and 30s. There have been studies on that where they've looked at the blood vessels in the carotids and in the coronaries of patients, and they see atherosclerotic plaques as early as in your late teens, 20s, and 30s.
Wow. So you got to catch it young, catch them young and get them out of the habit, because if it's a habit when they're a teenager and kid, they're more likely to assume obese is normal and continue on that path. And then, oh my God, 20s already are atherosclerosis. Yes. My goodness. Yes. So now I'm going to revisit a question I have here, because we talked about screening and we talked about sports and high risk. Do you recommend that all athletes get some sort of health screening before before sports?
Absolutely.
Okay.
Yes. Um, the debate then comes, what is that screening? To what level
Mm.
should they be screened?
Mm-hmm.
There is absolutely no question that a detailed history, a more specific cardiovascular physical exam with there are certain manipulations that you do during the physical exam, upright, laying down, squatting, and you're listening for certain sounds in the heart that may not be elicited through a regular physical exam. So that absolutely should be done in every child that is planning, and even adults planning for sports participation. The debate then comes to, should everyone get a 12-lead EKG? There are some instances, some countries where there's a higher risk of rhythm disturbances.
Mm.
And those countries, in Italy specifically, they do screening EKGs. Here in the United States, we don't. It's not part of the protocol. But I'm seeing more and more where highly competitive athletes, even at the high school and middle school level, their teams are requesting them be done. So I do think at some point along the way, we will get to the point where screening EKG will be standard practice. It's not everywhere right now. It's debatable.
Yeah. So
The
parents
debate
who
is
are
really, go
yeah.
ahead.
So parents listening should, yeah, if they can, can we do, if it's not too much extra money, or just can we add that EKG? It's something for parents that they can know about from listening here.
Absolutely.
Next is, I have a question about the U.S. government.
Mm-hmm.
And I've been following actually RFK Jr.'s presidential run. And he's looks like he's going to be involved in the government, make America healthy again.
Mm-hmm.
Are you looking forward to that? Do you think that there can be a sort of top-down federal government help for issues, or are you have no idea?
At this point, I don't know what his plans are. I have to be frank and honest.
Okay,
I
yeah.
haven't been reviewing that yet because I want to see, what actually is done before I can respond to it.
Okay.
Maybe once he implements or speaks more about it, it's laid out on paper, I'd be able to comment a little bit more on that.
He's famously come out against childhood obesity, that it's just totally unacceptable. And we have to basically pull out all the stops to get America healthy again. So whatever pull out all the stops means. But
yeah, and then the devil is in the details.
yeah.
What does that mean? Obviously, reducing childhood obesity is very important, and I'm a 100% advocate of that. And we do all that we can, at the micro level, which is in the offices, the pediatricians. It really, the real key is in the communities, is what I see. In your home, in your school, in your local environment.
So starting ground up, and the people around you, the community around you, and starting from there, ground up instead of top down.
And I think I'm not willing to say that there's no role for government in it. And I think there is. Certain mandates would be helpful, especially when it comes to, again, I don't know what his plans are, so I'm not really directly commenting on that. But when it comes to things like nutrition within the schools, kids spend a majority of their time, at least half of their day, in school. So I think the role of government in there is providing, or at least local government, in providing nutritious meals that are actually more nutrient-based, lower in fats, and also health education for the family, because it can't just be the child we focus on, it has to be the entire family.
Mm-hmm.
So programs like that, where we're putting, getting kids into the habit and families into the habit of the foods that are appropriate for them. Sorry, I had to close that off. The phone was ringing, I apologize. We have to get to the habit of, providing the right foods within the schools, and then educating families on what you can pick at home, but being very cognizant of what their needs are in their communities.
Mm-hmm.
Because, for instance, if a child is struggling with food insecurity, they don't have a way to get food that is fruits and vegetables that tend to be more pricey, and they don't have access to them because of their local markets don't carry them. That's going to be more of a struggle to get that child to eat healthier because they don't have the foods that allow for that.
Mm-hmm.
So if there's a way for government and private sectors to work together to make sure everyone has access to that. Now that's something I get.
Yes. That is a great point. It's the access. There's a lot of focus on so I have a diplomat with the International Board of Lifestyle Medicine in the States. It's the American College of Lifestyle Medicine or the American Board of Lifestyle Medicine, because I like what they do. I like their message as a medical specialty. Prescribing lifestyle changes, educating, as you said, for nutrition, and I've gone to some conferences or participated in conferences and listened, and okay, this is how to make plans for people in poor neighborhoods. These are ways to teach them how to make meals that are cheaper and cheaper, not necessarily cheap enough. But we forget about the access. And about what they can actually get. Sure, you can put peas and beans, and that can even buy those things at the local market. And it's another dimension I did not consider. And this advocacy, I like these lifestyle medicine boards, because part of the specialty and part of the education is, okay, everyone who becomes a member should be going out into the community, should be going to the hospital, making sure the hospital has health issues, should be going to the schools, should be participating in local governments, to educate the politicians, because we need to change the world. It's not a profitable specialty at the moment, but it's a meaningful one. Because how are politicians supposed to pass useful legislation or initiatives without a doctor coming by and telling them what needs to be done?
and on the same note, how will we do that without not only the doctor but also the people?
Yes,
we have to know what they need and what they will do, and that's really very at the micro level. Everyone has to work together for that to work. And one thing I've come across, if I may, when trying to introduce what I call heart healthy, what is fine for me is not necessarily fine for someone else within their culture, and what the foods that they like to eat and what they have, not just access, but what they're used to eating. So I think we have to we do absolutely have to take that into consideration, and that may even need to be at the front of the discussion of what we will do, how we have access to it, what is good for that community.
One of the last presentations I can remember, it was people were presenting what they had done, and it was at a hospital, and it was either they were targeting the Filipino population, or they're targeting some sort of Spanish speaking population. And they had created basically like a Spanish version of proposed diets, which were culturally sensitive, basically. So they're more likely to adopt it if it's just minor changes to something they're already used to eating and foods they already like to eat.
Exactly.
You're definitely right. So we're sort of winding up now. Do you have a final message for the audience?
My final message, I guess we talked about so many things, but I will say with regard to sports, now, again, 100%, it is very important to be active, get out there and move. The risk of sudden cardiac events is very low for children. Important screening and testing is critical. The level of testing will be directed by your pediatrician, but 100%, if there are risk factors, make sure you tell them so that they know what to do from there. And that's my take home for that topic.
Thank you. I thought of one more question. I'll squeeze it in. I'm actually a sonographer, an MSK sonographer.
Oh, No.
Is there room for, or is it advised to actually get a sonogram, ultrasound images of the heart to see the valves? Or is that like one of
Hmm.
the last steps?
The general answer is if you go down the flow chart of things, that will be one of the last things. An ultrasound of the heart is indicated if you've seen a cardiologist and they find something unusual or significant in your family history that they feel like won't be picked up by an EKG and family history alone. They might do a screening echo. I do them sometimes.
Okay.
Um, I do. And also, one thing I want to tell parents is that sometimes in your communities, there are free events. Look for them because in those free events, you often can get a screening 12 lead EKG for free or just a minimal cost. And sometimes you will actually get an ultrasound of your heart in those situations. So when you find those events, I would say jump on them. But I'm not opposed to the ultrasound, but I would also say this. Sometimes you end up learning things that you didn't know, and that might be good or bad, depending on what it is. It might make some people more anxious for things
Yes.
that aren't
So my
necessarily.
specialty is in MSK. So I have the RMSK, the physician level certification. Um,
Mhm.
so I'm looking at knees and joints a lot, and of course you see
Right.
arthritis, but arthritis has such a poor correlation with pain. And it's actually same thing
Mm.
with joint effusion. It has a very poor correlation with pain.
Mm.
Like seeing it doesn't mean the patient's in pain. Doesn't necessarily mean that that's findings associated with pain. And now we're
Right.
learning that bursitis isn't actually painful. It bursal fluid. You actually have the body will put extra fluid to cushion, to act as a cushion, but typically it's a tendon causing pain. So all
Right.
those people diagnosing with trochanteric bursitis and epicondylitis, it's like, it's not a pes answering bursitis. As sonographers, we're supposed to write in our reports, we're supposed to write increased bursal fluid instead of bursitis now.
Hmm. Hmm.
But yeah, we don't want to. I don't want to tell someone, look, you have severe arthritis. Oh, bone on bone. Just imagine it grinding. Ugh.
Right.
I say, oh, your knee is a little older than it should be, or your knee is a little younger than it should be, so that's good. I have little bone spikies. I try to,
Hmm.
gentle it, to try not to think about it too much. Treat the patient, not the picture.
Exactly. Exactly. And that's one of the risks with screening tests is that sometimes you end up with information that's not necessarily relevant to the question or problematic. It's just for some people that's a source of anxiety, and
Mm.
it leads to more testing that may not be necessary or end up with information you don't need at that point. On the flip side, you can find things that are a significant risk factor for sudden cardiac events. So, there's a balance there, but in general, most people won't go down that route.
Okay.
I will tell you, if you end up in a cardiologist's office, they will test you to the point that is needed to answer the question. And if it's sports participation clearance, many times you will end up with an EKG and an ultrasound.
Okay. So
Yeah.
thank you for the patience of that one more extra question. And thank you for being on the podcast. It was a pleasure.
My pleasure. Very nice to talk to you.
Cheers.
Bye.